So today I'm here with Heidi Rayala, MD, PhD, who is an assistant professor of surgery at Harvard Medical School and a practicing academic urologist at Beth Israel Deaconess Medical Center in Boston. Clinically, Dr. Rayala specializes in the management of BPH, OAB, and the complex urinary issues affecting aging patients. She has a particular interest in addressing lower urinary tract symptoms in patients with Parkinson's, focusing on patient-centered treatment approaches to improve their quality of life. She is a recognized expert in the medical management of urinary dysfunction and regularly lectures on optimizing care for patients experiencing urinary frequency and urgency. Her research explores ways to enhance the patient experience during ambulatory urologic procedures with a focus on the use of low-dose nitric oxide to alleviate pain and anxiety during office procedures. Dr. Rayala completed her medical and doctoral training at Washington University School of Medicine, where her PhD focused on molecular biology. She trained in urologic surgery at Brigham and Women's Hospital and pursued a urologic oncology fellowship at Memorial Sloan Kettering Cancer Center. With that being said, I'm going to turn it over to her, who will go ahead and start the presentation.
Thank you, Jackie. I just want to thank the organizers for inviting me to be here today and to speak. I'm really excited about this talk. I think as many of you experience, and even I experience on a daily basis, there are so few doctors and so many patients who need doctors that it is hard to get appointments with doctors. And for us as urologists, the demand far exceeds the number of us that exist. We have to curtail our appointment times to see all the patients that need to see us. And so, we really only get maybe 20 minutes, maybe 30 minutes to talk with a new patient. And so you can imagine it's pretty nice to be able to sit down with a group of new patients, right? And get to spend an hour with them and really talk through some of these things that normally were more rushed in the clinic setting. And I think, just as a caveat to being a doctor over a Zoom, there are some things I can't do today, right? So I can't check your urine to make sure that there's no blood in your urine, that there's no infection of your urine. But that's something that your primary care doctors and neurologists have probably done. The other thing I can't do is I can't scan your bladder to make sure that you're emptying appropriately. And the bladder's a funny thing. You can feel like you're emptying fine and still be totally full of urine. And so we need some of these objective measures, which I can't do over Zoom. But I can teach. And I love teaching about the urinary system and ways to make our symptoms better. So with that said, my goals today are to talk about the urinary tract system and understand why, first of all, in all women as they age, they begin to have urinary frequency and urgency. Why, for different reasons, in all men as they age, they begin to have urinary frequency, urgency. And then the reason we're here today, right? So these urinary problems also happen in Parkinson's patients for other reasons, additional reasons. And then I'll move into some of the treatment algorithms for urinary problems. And so I'm really excited to get to spend some time doing some bladder retraining techniques and provide you some resources. So make sure you have a pen and a paper or the ability to look something up on Google, because I'm going to give us a website to look at. And then talking about urine production at night, and then we'll go into some medication options. So when we think about the urinary tract system, right, if we back up and we say, I'm drinking a glass of water, when that water goes into our stomach, it gets absorbed into our bloodstream, and then that fluid has to get filtered into the kidneys before it becomes urine. And then from the kidneys, you're making the urine, and it's trickling down through the ureters into the bladder. The bladder is expanding to store that urine, and then when we pee out, it's through the urethra. This whole process takes about 30 minutes, even though I know it seems like I drink tea and then I have to pee it out 5 minutes later. So I want to kind of talk about that and help you understand that it's not that you just drank it and now you really do have to pee, but that you're having a bladder contraction that's making you think you have to pee. So in order for this system to work appropriately, the bladder needs to be a storage tank, right? So as the urine trickles down from the kidneys, it needs to be able to expand, expand, expand. And a normal bladder, a bladder when we're young and in our 20s and 30s, can hold about 500 milliliters, which is about 16 ounces. So 2 Coke cans, right? I think a Coke can's 8 ounces, or a glass of water is 8 ounces. And that ability of the bladder to stretch is what allows us to hold for 3 to 4 hours in a normal functioning system, and also to go to bed and sleep through the night without having to wake up. As we age, as everybody ages, as we start to get wrinkles on our body, it's because we're losing elasticity, right? And the bladder has elastic bands throughout it. And as we get older and we lose that elasticity, it makes it harder for the bladder to stretch. And so we lose that storage ability. The bladder needs to be a pump, right? So when we urinate, the bladder needs to push out the urine. And I'll just say that to remind ourselves that the bladder is a sphere. So when it contracts, there's always going to be a little bit of leftover urine. It can't invert to completely empty the bladder, because patients will say, well, I urinate, but then when I stand up and I sit down, there's still more there. And that's the way it is for everybody. But the problem is you shouldn't be bothered, or you shouldn't feel those extra remaining volumes. And so I know that can be a problem for people. And what we're going to also talk about are there are things, especially in men, that if the bladder is needing to push against a blockage, the pump gets damaged over time. And so we need to be thoughtful and kind of bring that into our picture as well. So when we think about the bladder as a pump, and we're trying to figure out if it's working correctly, this is the thing I can't do over Zoom. In our office, we'll often do what we call a bladder scan or an ultrasound. So we have the patient go and urinate, and then we bring them back and we do this little point of care ultrasound that you see in the image, and we scan how much is left in the bladder. And so ideally, we would see less than 100 milliliters or less than 3 ounces. And so in some instances, and this can happen in Parkinson's patients, where they go to the bathroom, they feel like they empty, I bring them back in, we scan their bladder, and there's like 300 or 400 milliliters. And then I know that there's something really going on with the ability of that bladder to pump the urine out. So when we think about symptoms that indicate our system, our urinary system is not working correctly, well, we have urinary urgency. That's that sensation that you need to urinate, making you fly to the bathroom. There's frequency, urinating more than normal. Normal is about every 3 to 4 hours. There's incontinence. There can be different types of urine leakage. So there's mainly with Parkinson's, and as we get older, it's what we call urge incontinence. You feel that need to urinate. You're flying to the bathroom, but you don't make it to the bathroom on time, and you leak on the way to the bathroom. Or you're done urinating, and your bladder keeps squeezing until you start to have dribbling after you leave the restroom. And then nocturia is waking up more than once a night to urinate. So this is where our talk is going to diverge, just like our roads will diverge for women and men. There are some things that you guys have in common, and there are some things that are different. And so I'm going to spend a couple slides talking about unique problems for women and then unique problems for men. But what I really want you to take home from this slide is that for every single person, urinary problems are multifactorial. There's many things that are contributing to it, and it's unique for each person, right? Which is what makes urology and working with Parkinson's patients such a challenge, right? For me, because I get to be a little bit of a Sherlock Holmes and figure out which of these is contributing the most for you. So, but all of these have a part. So there's the age-related loss of the bladder elasticity that I just mentioned. There's Parkinson's, which can cause some other specific overactive bladder and weak pump problems we'll talk about. And then in women, the loss of estrogen causes some significant problems, probably and possibly for you more than these other issues. And for men, similarly, as the prostate enlarges, it can cause problems. So I'm going to start with women. And there's this new term out. It's called the genitourinary syndrome of menopause, GSM. There's a lot of literature coming out in the last year or two about this. The old name for this would be hypoestrogenism, like low estrogen. It's so common, right? So, depending on what you read and depending on the age of the women, starting in their 40s, 36 to 90% of women experience GSM. I would say by the time you're in your 70s, 80s, every woman has it. And what's important to understand is that the symptoms increase in severity over time, and they will not improve without treatment, right? So these things are going to get worse. So what's happening? As you go through menopause and you lose systemic estrogen, there are some problems that occur in and around the vagina and the bladder. So the tissue, the estrogen helps there be stronger blood flow. It helps the tissues secrete moisture and be thicker. And so as you lose that estrogen, the tissues become thin. And so they have increased irritation. You may notice vaginal dryness, discomfort with sex. In addition, because you need that good blood flow to help the elastic properties of the bladder, you're losing more of that elastic storage of the bladder. The vaginal estrogen, for complicated reasons outside the scope of this talk, but it helps protect you against urinary tract infections. So as you lose the estrogen in the area of the bladder and the vagina, you're more susceptible to getting recurrent bladder infections or UTIs. And then also, when we talk about urinary incontinence, there's also stress incontinence. And that's the one we normally associate with women after they have children. So you cough, sneeze, and you leak. And interestingly, that when you have a child, it kind of damages your pelvic floor muscles, and that's why you can have that type of leakage. Also, when you go through menopause and you lose your estrogen, those pelvic floor muscles aren't getting the nutrients and blood and nerve supply that they need. So you can develop new onset stress incontinence. All of these things have been shown to get better with vaginal estrogen, right? So when we think about this treatment, it's a vaginal estrogen. So we're putting in an estrogen within the vagina. And there are different modalities of treating this. There are little Vagifem pills that you use as a suppository to actually put inside the vagina. There's capsules, there's creams. For patients who have lost some of their finger dexterity, there are actually rings that can go into the vagina that stay in for 3 months, and your doctors can change those out for you. And you're thinking to yourself, well, why would it matter if I fix the estrogen in the vagina? And the answer is that the urinary system is back to back with the vagina. And so all of the medicines that you put in the vagina are also having effects, local effects on the bladder. And this has been shown in many different studies to be the case. The thing that my patients will often say is, wait a second, vaginal estrogen, these, I've heard these are bad. And so I want to just make a couple comments on vaginal estrogen. So first of all, super important to understand is that it's going to take 3 months to begin to see the positive effects of vaginal estrogen, right? And once you start to see those positive effects, you need to stay on the medicine. If you stop the medicine, you'll still feel great for about 2 months until the estrogen wears off and you start to have the problems again. So again, you're taking an estrogen tablet to improve blood flow and the mucus secretions of this area. And it takes a while for that to start to happen, to get to renew that blood flow and nerve innervation of that area. So what about the concerns about estrogen? So I think what's important to just briefly touch on is that when we think about the risks of estrogen therapy, those are systemic estrogens. So people who are taking pills by the mouth or the patches. Historically, there was some studies that showed there was an increased risk of heart attacks, stroke, breast cancer, blood clots in postmenopausal women. But if you've paid attention to the New York Times or any of our news programs, this data is really now being called into question, and the actual risks were quite small. So maybe 1 in 17,000 women who were on these medicines. However, and above and beyond that discussion, we're using a vaginal estrogen. The systemic absorption of these vaginal estrogens is thought to be low, and the risks are thought to be minimal. Now, if I have a patient who has a history of breast cancer or who has a recent blood clot, of course, I'm going to talk with their oncologist or with their PCP and make a decision that's best for the patient. But overall, I try to reassure my patients not to get too worried about the risks of the estrogen. All estrogens have to have this warning. So when you get a vaginal estrogen, it has to have all these warnings, even though this is a local effect estrogen. Okay, so let's move into men. So what happens in men is they develop benign prostatic hyperplasia. Okay, this happens to all men. So when we think about the prostate, this is a gland that sits right below the bladder, and its function is to make components of the sperm when you have an orgasm. Anatomically, when you urinate, the bladder is squeezing out the urine through the middle of the prostate. All right, so the urine's passing through the center of the prostate, which wraps around that urethra, kind of like a donut. And starting at the age of 45 to 50, the prostate starts to occlude or obstruct the lumen. It's happening for 2 reasons. Part of it's that the prostate's getting bigger, right? It's growing. And interestingly, this tends to run in families. So I always ask my patients, did your dad or older brothers have problems with their prostate? But part of it is actually that there's an increased muscle tightening. So you're getting more muscles in your prostate as you get older. There's nothing adaptive about it. It's poor design by somebody higher than me. But basically, it's getting blocked and your bladder's having to work harder to get the urine out. So yes, the prostate can also get cancer. And of course, that's what patients worry about. We use the PSA blood cancer screening most of the time in this era of PSA screening. It would be very uncommon to have a prostate cancer that would result in urinary symptoms with a normal PSA, right? Prostate cancer tends to be in the periphery of the prostate, tends not to generally block the urine flow, at least early in the disease when we would catch it with PSAs. So I just kind of described the system, and now I have some cartoon models that I want to kind of talk about. So you can imagine in our normal system, if you start blocking the outflow of the urine, the bladder pump has to compensate. And the way that it compensates is that it gets very muscular, right? So the bladder is a muscle. And as it has to push harder, the bladder muscle wall gets thicker and thicker. And by definition, as that happens, the bladder's capacity gets smaller. It can't hold as much. And all this extra muscle is more susceptible to irritation and makes you you get a little bit of urine in your bladder and it's wanting to squeeze and it's causing you to have urgency. We also are beginning to understand now that if we don't fix the problem, right? So now if we don't start a patient on a medicine for this problem or do a surgery for this problem, the pump can get damaged. So the bladder over time, if it keeps having to push out, will develop permanent damage that we can't fix. And you get these kind of big blown out bladders where like the post-void residual, when we scan their bladder, it could be like 500, 600 or a liter. And we know can't fix that bladder. Even if we fix the prostate, the bladder damage is permanent. So we're getting, just as a urologist in space and time, this past 5 years, we've really focused on trying to be more proactive at fixing this problem before we get to a place where we can't help the men. especially because, and I'll say this also for women, right? Patients are living so much longer than they were, right? The average length of life was 75 years old. Now it's not uncommon to live into our 80s and 90s and still have a really good quality of life. And so these problems, which we weren't running into as much in the past, now are rearing their ugly heads. So let's think about medicines for the prostate. And I like to break our medicines when I think about it and describe it into for patients as our prostate openers and our prostate shrinkers. And so I want to talk about the prostate openers first. So these are medicines that relax the muscles in the prostate and help them open. We're probably familiar with some of these medicines, Flomax or tamsulosin. Another common one might be alfuzosin, uroxetrol. There's also, I'm including in this list of medicines, Cialis, which is an erectile dysfunction med, but on a daily basis also helps open up the prostate. So again, all of these medicines work by relaxing the muscles in the prostate, opening the lumen so the bladder doesn't have to press as hard. So there's side effects with these medicines. In about 10 to 15% of men, they'll have loss of ejaculation with orgasm. So erections are normal. They have a good orgasm feeling, but they've lost the ejaculate. And for some men, that can really ruin the way the orgasm feels. And then the other thing that we talk about is low blood pressure. And ding, 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 this is going to be really important in our Parkinson's patients to think about. And you may have run into these problems before where patients with Parkinson's already have problems with low blood pressure. So with these medicines, they tend to lower the blood pressure and cause some dizziness for the first day or two, but then your body should adjust. And in Parkinson's, they may not always. So I warn my patients when you first start taking it, look for these symptoms. And then just so that you know, there are some of these medicines that have less effect on blood pressure. So I tend to start with silodosin or alfuzosin in my Parkinson's patients in order to circumvent this problem. But sometimes we can't use these medicines in Parkinson's patients. So then we have the prostate shrinkers, finasteride and dutasteride. The studies have shown that these medicines are really best for larger prostates, and we define larger prostates for this purpose as being more than 50 grams. And your doctors can arrange an ultrasound for you to have your prostate measured if this is helpful to deciding whether to start these medicines. The way that they work is over the course of time, they shrink the prostate by about a quarter, right? They're not going to take a 100-gram prostate and make it small and normal again, but maybe get it down to 75 grams, which may be all that you need. And it also slows, or at least markedly slows, the future growth of the prostate. And the way that I explain this to the patient is, look, if you've already had half your prostate that's replicating quickly, those baby cells are going to continue to replicate quickly. So you're on an exponential growth pattern. This medicine, you're taking a pill, just like the vaginal estrogen, it takes time to work. So if you're taking a pill to shrink something in your body, I don't think it's surprising to think that this is going to take 6 to 12 months for you to start to see the efficacy, whereas the other medicines will work in a week or two. Side effects, 5% of men will have a decreased libido. I always remind my patients that 100% of men in their 50s, 60s, and 70s have a decreased libido. This is a decreased desire to have sex, not your ability to have sex. And that is due to the lowering testosterone as we age. And so I tell patients, don't overthink it, because we know you already have a decreased libido. And so give the medicine a chance. If you Google this, you'll also see that there's a risk of depression or breast growth or tenderness. These risks are very small, less than 1%. And the depression actually is been shown to be short-term. It tends to go away. But if you're having these problems and they're not, then you can always stop the medicine and these problems should go away. For those men who fail medicine or surgeries, and what I tell my patients is that about 80% of men, we can get where we need them to be on medicines, and then about 20% of them, we need to think about surgeries to open up the prostate. There are a plethora of different options outside the scope of this talk. But what's important to know is that the choice of surgery really gets down to the size of your prostate. Smaller prostates will do better with some surgeries, whereas larger prostates really require a different approach. And so you can read about these different procedures and think one might be great for you, but without actually seeing a urologist, knowing the anatomy of your own prostate, you won't know what's the best option for yourself. Okay, so we've talked about some things that are unique to women. We've talked about some things that are unique to men. And now let's focus on some things that are specific to Parkinson's. Not surprising to anybody on this Zoom call, about 63% of patients with Parkinson's have urinary symptoms. In general, the onset of urinary symptoms in Parkinson's patients is about 5 to 6 years after they start to have motor symptoms. The rationale, the reasoning for this is really complicated. It's not only complicated neurologically, but we clearly fully don't understand it all. And the science on this and our understanding of it changes year to year. But the results of Parkinson's on the bladder are, number one, it causes overactivity. Your bladder is squeezing when it shouldn't. At the same time that your bladder is squeezing when it shouldn't, it's also weaker. And so what I can't tell through the Zoom phone call is how weak is your bladder? You're squeezing your urine, but are you getting all the urine out? And then in order to hold our urine, when our bladder contracts, we have a sphincter that we involuntary, your body will squeeze that sphincter. And in Parkinson's, there can be some discoordination between when the bladder squeezes and then your body releases that sphincter. And then last but not least, and one of the things we're going to cover is nocturia, so urination at night, very common, and it actually is due to making too much urine at night. So we'll talk about that. So I want to first focus on these symptoms of urinary frequency and urgency. Again, this is a little bit of a complex problem. The bladder is having involuntary bladder contractions when you don't want to have them, and you have a decreased bladder capacity. So both of these things are related, and the treatment recommendation, first line for all patients who have urinary symptoms with Parkinson's, is to do some bladder retraining. And the idea is that if we can teach you how to understand and control your bladder contractions, over time, you'll be able to improve your bladder capacity. So I want to talk with you about what is urinary urgency and what that actually reflects and represents in your bladder. When you feel that urge to rush to the bathroom, even though you just urinated, when you feel that urge when you're at the door and you hear the lock, when you are sitting near the sink and the water starts running and you feel that urge, what I think is very important to emphasize is that sense of needing to urinate is not coming from your brain, right? This is not something you're making up in your head. You're actually having a bladder contraction that you should not be having happen, right? It's an undesired time for that bladder to start squeezing. The bladder contraction gets worse and worse and worse. I have to go, I have to go, I have to go, I have to go. And then the bladder contraction does, in the majority of cases, dull. It goes away, right? So there's an upswing and a downswing. And we don't often leak because we can squeeze our outlet valve, right, our sphincter. So when I'm going to stand up here, and you probably don't see my picture, but when your bladder starts to squeeze, we can hold it. It is incredibly hard for our body to coordinate holding that when we're also walking, right? So when we're walking, it just makes it that much more difficult. That's why it's our body's natural instinct to freeze, cross our legs, and bend over, right? We're trying to help our bodies from leaking by squeezing that sphincter. So this is what I would love for you guys to write down or pull up in a background Google screen or your browser of choice. So what I want you to look up is this SUFU OAB CCP, which will take you to the SUFU site, which is the Society of Urodynamics, Female Pelvic Medicine, and Urogenital Reconstruction. This is for women, but also for men. We use these tools for our men with large prostates all the time. And when you get to the care pathways, you'll see changes you can make to improve your bladder problems. And I'm going to go over one of my favorite handouts, which is controlling your bladder urges. There's a hyperlink in English. And this is kind of what it looks like. And it starts out with that picture I just showed you, right? That urge wave is actually a bladder contraction, and it goes through and describes it for you. And then it gives you some tools. So the first tool we want to learn is that when that urge strikes, we don't want to rush to the bathroom, right? We want to work and to overcome our desire to urinate so that we can work to improve the size of our bladder. So when the urge strikes, stop, stay still, sit down if you can to wait out this contraction. They talk about squeezing your pelvic floors. This is not Kegel exercises. This is just, some people have shown that if you squeeze your buttocks or even do like Kegels, it will make the contraction go away more quickly. You want to relax and wait for that urge to go away. Once the bell curve comes back down, you're going to have a little bit of window where the bladder can't really mount another strong contraction again. So that's your window to walk to the bathroom at your normal pace and urinate. Once you can do this, you want to start working on delaying your urination, right? So instead of walking to the bathroom right away, try waiting for 5 minutes before going to the bathroom. And once you can do that, trying to push it out to 10 minutes. Our goal is where we were when we were younger, every 3 to 4 hours per day. So for my patients, I will often draw out a urination schedule to work on stretching that bladder capacity. You kind of need to figure out where you are on this little graph I drew, and maybe you're going every 15 minutes or every 30 minutes. But what I generally say is you can't do this overnight. A person who has a small bladder who's urinating every hour physically can't hold their bladder for 4 hours, right? And so what we want to do is slowly over the course of months, work to improve your capacity. So if you're going every hour over the next 1 to 2 weeks, just try to work towards holding it for 1.5 hours. Once you can do that, work towards 2 hours and moving forward so that you can get to a goal of 3.5 hours. Some people find this difficult because they drink at certain parts of the day and they're like, you know, I'm not certain, maybe I had to pee because I had to drink. And so another way of doing this is you can look at urination volumes, okay? Sometimes this is a good tool to just show you how small your bladder capacity is, and then it also is giving you some positive feedback to know that you're improving. So when we think about this, I can ask patients to pick up a urinal or a urinary hat from the drugstore. Sometimes your doctors can give you one. You can make your own. You can take a yogurt cup and just mark off your volumes. But in this scenario, instead of working towards time, we're working towards volume. You may find that, oh my gosh, she's right. I only urinated 100 milliliters. And I've told you that a bladder can normally hold 500 milliliters or 16 ounces, 2 cups. And so what you want to do is over the course of time, work towards improving the capacity. So some people say, I'm really struggling. What else can I do? And or they say, but my doctor says it's all the caffeine. And so I'm also going to show you this handout, 5 changes you can make. And it just points out that there are some foods and drinks which irritate the muscle of the bladder, right? And are causing more bladder contractions or stronger bladder contractions that are making you fly to the bathroom. So foods that we know are particularly bad are caffeine and actually carbonated beverages. Carbonated beverages isn't on the list. I added that. So the way I describe it to my patients is anything that burns, irritates, makes your mouth tingle can also have that same effect on the bladder. And none of these foods or drinks are going to make your problem worse in that it's not going to cause a problem with your bladder or your prostate, but it will cause you to have urgency for the 3 or 4 hours that you take these. And so sometimes as we start out the bladder retraining, we may cut back on these. Honestly, my goal is that as we improve our bladder capacity, we can add some of these things back. It's counterintuitive, but as your bladder gets bigger, you won't have as many of those overactive urge contractions. Okay, well, so you've tried cutting out your diet, you've done the really good elimination diet, and you've worked on the bladder retraining, and you're not making any progress. Well, what else can you do? So these are things you can talk to your doctor about, and what your doctors will often first turn to is adding a medication, right? So a medication, these are the anticholinergics or the beta-3 receptor agonists. All of these medicines work to inhibit the neurologic signals to your bladder that are telling your bladder to squeeze, right? And so what we want to do, so what they're doing is they're basically, I'll say, lightly paralyzing the bladder so it's not squeezing as hard or as frequently as it was before. The old common ones that we've talked about that maybe you've been tried on are medicines like oxybutynin, Detrol, Vesicare, trospium. And these medicines work by relaxing the bladder. The thing that's important to remember about all these medicines is that they will improve your symptoms by kind of masking the symptoms, but they're not going to fix the underlying problem, right? So if you have a large prostate, or if you have low estrogen, well, especially for men with large prostate, you can actually mask the symptoms or the problem as it's getting worse. So it's important to suss out those other etiologies. I think it's important to pause when we think about anticholinergics. There are some warnings. There have been many studies that have found significant association of these medications with cognition, memory. And there was a big article that came out in 2019 in JAMA that really showed that these anticholinergics are bad actors, hit the New York Times. So we're thoughtful. We're thoughtful, especially in our patients who have Parkinson's and are already struggling with some of these problems. So then these new medicines came out, right? The Gemtesa, the mirabegron, the mirabetrol, the beta-3 receptor agonists, and the purported benefit of these is that it doesn't have these cognitive effects that the anticholinergics have. And that, while being true, also doesn't make up for the fact that these medicines don't work as well as our anticholinergics. So there is a lot of money spent on mirabetrol and Gemtesa because the drug companies still make a lot of money when you get your doctor to prescribe these for you. But when you actually go in and look at the data and the actual improvements in symptoms, it is not a marked improvement. So just some things to keep in mind with all of these medicines. Number one, for Parkinson's, these medicines can help with that overactive contraction, but they're going to worsen that bladder weakness, which can lead to retaining of urine. And so if you're working with a good urologist, they'll check your bladder scan to make sure that after you start this medicine, you're not retaining urine. One of the signs of retaining urine is getting bladder infections. You can imagine that if you're not getting all the urine out, then there's this nidus for the bacteria to grow. Sadly, there has been a study, a clinical trial of mirabegron for patients with Parkinson's disease that didn't show an improved benefit over placebo. That didn't make the big news because it kind of got silenced by the people that did the study, but the data is out there. All of these medicines also slow the GI tract. So if we think about slowing the GI tract in our mouths, that means less salivation, which means dry mouth. which can, if it's long-standing, lead to dental cavities. It also slows our bowel, so it can result in constipation or worsening of constipation. I do use these medicines. I tend to use them short term. So I basically, if a patient is failing on doing the bladder retraining on their own, then I will use these medicines short term. Maybe I'll do it for a month to help them get through that initial hump of getting their bladder bigger. And then I also use them as needed. So these are not like a blood pressure medicine where you need to take them daily to see the effect. You can just take them on one day and then not take it for a month. And so maybe my patient uses it when they're traveling or when they have a movie date. I tend not to use these medicines long-term because I worry about the side effects. Lastly, nocturia. Nocturia is common in Parkinson's patients. So what is nocturia? It's excessive urination production at night. We define it as waking up more than one time at night to urinate. So we'll accept waking up once at 1 a.m. to be within the realm of normal. But if you're waking up at 11 and at 2 and at 4, well, that's clearly not normal. When we think about why do people have nocturia, in young patients, they also can get small bladders for various reasons. And so if you have a small bladder and you're urinating frequently during the day, that same bladder can't hold the urine at night, so you're urinating frequently. But in our older patients, and specifically in patients with Parkinson's, it is more often to be nocturnal polyuria. That is, your body is making too much urine at night. And I'll back up by saying our bodies are smart. In general, when we're young, our kidneys actually shut off urine production at night so that we can sleep. It's adaptive. And in Parkinson's, and as we get older, there can be problems where the kidneys actually do the opposite and start making more of the urine at night, resulting in us waking up. So the way that we diagnose this is avoiding diary. It seems like old school, but we just have patients record how much urine they're making during the day, during the night, and you can do this at home. So I send my patients home with a little graph like this, and I say, when you wake up in the morning, record how much you urinate, dump it out. The next time you naturally feel like you should urinate, let's say that's noon, record how much you're urinating, dump it out. And then what I want to do is I want to calculate how much urine they're making during the day and how much urine we're making at night. And you count the first urination in the morning, of course, as your nighttime production. And I'm just going to give you a good example of somebody with Parkinson's and avoiding diarrhea that they brought me. So remember, a normal bladder can hold 500 milliliters. And first of all, I see, oh my gosh, during the day, they're urinating about every 2 or 3 hours, and they're small amounts. So they could, if we could get this bladder to hold 500, we could probably get more hours in between their urinations. But then interestingly, what I see is at night, there's a void of 600 and a void of almost 400. And I think to myself, well, golly, this bladder actually can hold. So we need to probably just work on bladder retraining. It's probably their capacity is okay, but their real problem is that at night they're making over a liter of urine, and during the day they're making half a liter of urine. And there's no urologic medicine or surgery that will make this better. This is a problem with the kidney production. So you need kind of more like nephrologists, like the medicine doctors for the kidneys. When we think about nocturnal polyuria, making too much urine at night, there's generally 2 ways we think about it. It's either cardiac, heart in etiology, or sleep apnea. And so I'm going to give a slide on both of these. So what do I mean by cardiac? Well, in patients whose hearts are weakening, they're not pulling back the fluid, the heart into the system the way it used to. And or in patients with Parkinson's, like the systemic vasculature is not working as well. So the blood vessels are letting more fluid into the lower legs, right? So you get swelling of the lower legs. You can also get a little bit of fluid on the lungs. And then at night, when you're lying down, that's the opportunity for your body to pull in that fluid, that extra fluid in your legs, pull in that extra fluid from your lungs, and then your body's got to get rid of it, right? So it's got to pee it out. So when we think about ways to help that process, we talk about simple things like trying to restrict your fluid intake 3 hours before bedtime, thinking about elevating those legs to get some of that fluid resorbed in the hours before bedtime. So hopefully you can pee before you urinate or before you go to bedtime. Compression stockings and physical exercise, right? So when you're walking, your calf muscles are contracting, 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 and that'll help push the fluid back into your circulatory system as well. So what about sleep apnea? One of the weird side effects of sleep apnea is excess urine production at night. And it has to do with when your body has sleep apnea, it thinks you're volume overloaded, so it's inappropriately diuresing at night. We used to say that people with sleep apnea were the ones who snored, who were overweight, who were waking up gasping at night. But we now understand that there's maybe half of our patients don't have those findings. And so there's some idiopathic sleep apnea we don't fully understand, but those patients will inappropriately make too much urine at night. CPAP machines, makes sense, can actually improve that symptom of nocturnal polyuria. Medications won't work for a problem where you're making too much urine, right? So prostate meds aren't going to help those kidneys to shut off. Your anticholinergics, your overactive bladder medications aren't going to help your kidneys shut off urine production. There is a medicine called desmopressin or DDAVP that does have a recommendation for using. Recall, though, that you're only shifting the urine production from the night to the day, right? Your body still has to get the urine out. And this needs very careful monitoring because it's mucking around with some of the hormones, and because of that, it changes your electrolyte levels and you can cause EKG changes. And I will say that I would say half the patients that I tried on this medicine, and I haven't used it that commonly, but about half of them develop this sodium imbalance, and we have to stop the medicine, and it needs to be monitored carefully. Okay, so you've tried the bladder retraining, you've tried the medicine, and it's still not working. Well, so that's when you need to see a urologist, right? And what I do for my patients, where I'm just, we're scratching our head and saying the usual things aren't working, is we do a urodynamic study. And a urodynamic study is a pretty complicated study. We put a catheter in the bladder and a catheter in the rectum. We fill up the bladder. That allows us to determine, well, what's their capacity? Do they have that really small bladder that I've been talking about, or do they have a normal bladder? And then we have the patients, while all these catheters are in place, we have the patient urinate, which is hard. And when they urinate, we can determine how strong is that bladder. Is it weak? More importantly, we can also calculate if there's a blockage, because I can see how hard is your bladder having to squeeze to get that stream. And so in a man, if I'm seeing that the bladder squeezing, gangbusters, but there's a weak flow, well, then I know there's a blockage. And maybe the blockage isn't responding well to the BPH meds, and so we need to think about surgery. And again, we check your urine for blood, infection, cancer. Maybe we do a scope inside if we do find some of these things. We check a PSA to make sure we're not missing a late onset prostate cancer. And for some patients with Parkinson's, they'll respond to the deep brain stimulator. That's not something urologists do, but we've seen it improve urination. We can, in very select patients, consider bladder Botox, but you'll remember what I said, that in Parkinson's, the bladder is already pretty weak. So if we do Botox to really weaken it, we can put them in retention. And I can't really think of any Parkinson's patients that I've had a good response with the bladder Botox, but it certainly has been written about. And then we can think about surgery procedures to unblock the prostate so that even if their bladder is weak, they can get the urine out. And then for some patients, we're limited, right? And their quality of life is such, maybe they're bedbound. And then we start to think about chronic catheters, condom catheters, and things like this. So I am on time. We've talked about the urinary tract system. We've talked about why it's worse in all women and all men as we hit 50 and how that gets exacerbated by Parkinson's. We talked about bladder retraining. I gave you those tools. We talked about the nighttime and why you might be struggling there and the meds. So with that, you get your cute kid pics, which means that you've reached the end of the talk, and I am open to any questions. And I will say that at Beth Israel, since many of you are Beth Israel patients, we used to have Dr. Das, who really specialized in neurogenic bladders. He was amazing, but he went to go be a chair in New York, so he's not with us anymore. And so right now that I will see some of the Parkinson's patients, but I also have limited availability. So I think that it's hard. It's hard to find somebody who specializes in this area. We also have Dr. Yana Barbalat, who's at Needham, who sees these types of patients. If somebody said this is scary, is there hope? I don't think of it as scary. I think of it as a puzzle, and trying to figure out what's going to work well for each individual patient. And I think we have good tools. So I certainly worry more about my patients with cancer and things like that. So possibility of proof. So I can't. So there's a question about deep brain stimulation. And again, I'm a urologist and we're so subspecialized, but I will tell you that I can think of 2 or 3 patients who, once they had their deep brain stimulation, their urinary symptoms improved. You guys will probably notice that when your Parkinson's symptoms are worse, your urinary symptoms are worse. And when your Parkinson's symptoms are better, your urinary symptoms are better. Pumpkin seed oil. Okay, so we're talking now about the prostate and the non-pharmacologic, so the herbals. So whether that's salt, palmetto, or pumpkin seeds. If you look at the Cochrane database, there's some evidence that these herbal supplements do help with urinary symptoms. What I always say to my patients is, it's not going to hurt you. It's not going to help you as much as the medicines. And if the saw palmetto or the pumpkin seed oil actually worked well, the drug companies would have already put it in a pill and be selling it, or the chemical component of it. So there's a reason it hasn't made it to be an FDA approved drug, and it's because the studies don't show a significant improvement, and certainly not the type of improvement we see with the alpha blockers like the medicines like tamsulosin. Cognitive problems, yes, right. So that is really, really hard, right? So when you have Parkinson's, it can make it hard to remember. And your brain can ruminate, right? It can think about, oh, do I need to urinate? Oh, I don't know. Maybe I have to urinate. I don't know if I have to urinate. I should go urinate, right? And so we know that that's a struggle for our Parkinson's patients. And so it helps if you have somebody with them who can support them and tell them, but there's not going to be a great solution to that problem. But certainly, I empathize, and I certainly see that. At what point do you see a urologist? Well, okay, so if you see blood in your urine, if you're a man and you're getting recurrent infections, if you're a woman and you're getting recurrent infections, you have to see a urologist. And then if your problems are getting worse and not better or not controlled on like bladder retraining, see a urologist, because we need to make sure you're not retaining urine. And or if you can't get into I know somebody said yesterday, I'm booking out until like October. So if you can't get in to see a urologist, ask your primary care doctor to schedule an ultrasound with radiology, and they can at least check your post-void residual, and your doctor can reach out to us if there's an issue. So the question is, if you've stopped the estradiol and now you think you have a UTI, can you start up the estradiol and correct the problem? So the short answer is, if you have a UTI, you're probably going to need to be treated for that and get your bladder well. The vaginal estradiol, you can definitely just start up again cold turkey, but it's going to be, again, 3 months before you start to see the protective effects of the estradiol on the bladder. I think I answered the question about the herbal products. They're not compatible with the BPH meds that we kind of reviewed, and catheters. So, yeah, I mean, it all depends on where you are in your quality of life, right? Like if you're up and doing things, you may not want to have a catheter. And there's actually, you can put in a catheter, and we have this thing called a flip flow, where if you have the manual dexterity, you don't have to have a bag, you can open, close it. The catheters, they need to be changed every month, so it's a trip to the doctor unless you can get VNA to change it at home. And the catheters can be associated with increased infections. However, if you're already not emptying your bladder completely, the catheters actually then are better than your baseline of not emptying, right? So not emptying, you can get infections. The catheter actually helps that.
The question is, are antibiotics always necessary for UTIs, or are there other solutions?
Yeah, so if you have a bladder infection, you should treat it. And when I have a patient who's getting what we call recurrent bladder infections, I think it's important to understand that, well, let me back up since I have a second. When you get a bladder infection, it's not that the urine is infected. It's actually that the bacteria has gotten into the walls of the bladder. And when it gets into the walls of the bladder, it kind of rips the mucosa of the bladder wall. So you can take an antibiotic for a week. You can clear your infection. But then, you know, we always get a little bacteria in our bladder, and now they can go right back in those crevasses and make a new infection, right? So you're getting a new infection. And so sometimes if it's a chronic problem, we'll treat them for 7 days, and then we'll put them on a low dose antibiotic for 3 or 4 weeks to allow the bladder to heal and be able to fight off future bacteria. We didn't always have antibiotics, is the short answer, right? You know, like there was a day before penicillin existed, women would get bladder infections, and most of them clearly were able to fight it off. So your body can fight off infections. I tend to just be really hesitant about making that suggestion. I'd rather the patient get the infection treated. And also we talk about asymptomatic bacteria. Oh, you have bacteria there, but it's not causing symptoms. Please remember that as we get older, we won't have the garden variety symptoms that we had when we were younger. We may not have the burning. We may not have the blood. But if you notice that you have worsening urgency, urgent incontinence, frequency, waking up at night, those are symptoms of a bladder infection as well. And if those symptoms get better on an antibiotic, then you know that the antibiotic was important for you. Good question. Prostatectomy surgery is preferable in men with Parkinson's? I would say no, because if you need a prostate surgery for your prostate, again, it really gets to the size of your prostate. If you have 100, 120 gram prostate, I'm going to recommend a HoLEP and or maybe an aquablation. Aquablation's great. It helps you retain your sperm, but it's not quite as good at opening up the prostate as like the laser enucleations. If you have a really small prostate, I'm going to recommend a TURP, right? So it really depends not on your Parkinson's, but on the size of your prostate. So, all right, Jackie, really wonderful. So pleased to be able to be here today and share my thoughts on this.